Good evening, all the aspirants present here. Today, we are going to have a discussion on neurological disorder. It is a class 2, and the speaker that we have here is Dr. Varun Pushkarna. He is a senior consultant in internal medicine at Fortis Escortis Hospital, Amritsar. So, you may take over. Thank you.
Thank you, Sana. I hope the slide is clear and visible.
Yes, sir.
Okay, great. So, welcome, students. So, we'll be covering the second part of the neurological uh, diseases for EDIC part 1. And we'll begin with the MCQ so that we cover all the important topics, and then we go through the brief, discussion of all the topics that we will share. So the first question, and I'll be letting you know the topic of question already so that your mind runs like that. But then eventually in the examination, you will not be given the topic along with. So focus on everything as if you don't know the topic. A 42-year-old man presents to the emergency department with progressive weakness in his legs for the past 3 weeks. He has a history of diarrheal illness 1 week back. Neurological examination shows areflexia and bilateral lower limb weakness. He's now developing shallow breathing. ABG shows a normal pH with CO2 of 29 and oxygen of 85 on room air. Which of the following is most appropriate step in the management of this patient? Start high dose methylprednisone, obtain a contrast MRI of the spine, begin IVIG, intubate the patient and initiate the mechanical ventilation, or start the plasmapheresis and corticosteroids. Anybody? Hello, yes? So the correct answer here will be anyone? So this patient basically looks like to have a progressive neuromuscular deficiency, which is ascending in pattern, which is most likely fitting in the bracket of Guillain-Barré syndrome. Now the thing is that this patient has now developed a shallow breathing. Shallow breathing means signs of respiratory muscular weakness. So this is the clue to the answer. So the CO2 is started to get washed out. PO2 is okay, although a bit low, but then still okay. So this patient basically is developing a respiratory muscle involvement. And we all know when the respiratory muscle involvement begins in a patient of GBS, the patient needs intubation and ventilation on elective basis. Now, this is where the intensivist's role comes in, to identify those patients who will and are in the immediate need of intubation and ventilation. So this patient has all the signs of impending respiratory failure. Now, am I audible to all of you? Hello? Hello?
Yes, sir, you're
Am I
audible.
audible? Yeah. So basically, as an intensivist and a candidate who is appearing for EDIC examination, it is very important for you all to understand and know when the patient will start needing intubation. If the patient collapses, even the staff nurse can tell you that the patient has collapsed. Now, please intubate this patient. But as an intensivist, it is your responsibility to identify the patients when they are in an impending respiratory failure. That means if you intervene now, there are high chances of the patient survival. So this patient will need intubation and mechanical ventilation. So correct answer is intubate the patient and initiate mechanical ventilation. This patient is showing clear-cut signs of respiratory muscle involvement. Tachypnea is there, PaCO2 is low, shallow breathing is there, and we know the diagnosis of GBS is there. And unless intervened by a IVIG and probably plasmapheresis, the patient is not going to get better. So you should make arrangements for the safe administration of IVIG or carrying out a plasmapheresis, but before that, the patient should remain alive. So if that doesn't happen, then there is no fun of knowing what to do and when. So intubate the patient when the patient has started to show earliest signs of respiratory depression, which is tachypnea, not maintaining CO2 levels, CO2 falling down, and the obvious visible using of the respiratory accessory muscles. So once the patient is intubated, you can always take up this patient for a plasmapheresis or IVIG afterwards. Now, what is your stand on corticosteroids in GBS? Anyone?
Corticosteroids are contraindicated in GBS.
Correct. So these steroids, they have no role to play in Guillain-Barré syndrome. If at all, the data is only for IVIG and plasmapheresis or combination of both. So the survival benefit is there with only these two modalities. Some people have also used rituximab, but then this is such an acute onset disease that only IVIG or removing the antibiotics, the antibodies that are affecting and causing Guillain-Barré syndrome, they need to be effectively removed from the system. So that is the only plausible treatment. MRI spine is not required because the diagnosis. How will you diagnose GBS? Anyone?
Nerve conduction study.
So number one, the diagnosis of GBS is basically based on very high clinical suspicion. So why? Because the patient's clinical presentation will be such that the patient will have a respiratory depression after a long standing ascending kind of a paralysis. So the patient will give you a history. Now the prognosis worsens with the length of time required for the paralysis to reach the respiratory level. So if somebody has had a tingling sensation on their feet last night and today they are not able to breathe in the morning, then this patient is most likely an axonal variant and a very aggressive type of Guillain-Barré. But otherwise, many times, many patients, they will tell you that 3-4 days ago, I started having this numbness feeling in my feet. Is there any other condition that you can pinpoint which can mimic Guillain-Barré syndrome in Indian settings? Because we are talking of the clinical suspicion. Anything else than Guillain-Barré which can mimic the same progressive paralysis? Sometimes it is the whole body paralysis, but usually I have seen few patients who also present with the similar feature. It is basically snake bite envenomation. So many times when happen is somebody got bitten by a snake and then a neurotoxic snake, and the dose of the venom was mild or moderate or somewhere in between. So not a lethal dose, not something which will cause immediate respiratory paralysis. So these patients will come to you after 3-4 days, and then you will many times need to assess the patient on the basis of snake bite envenomation also. Nevertheless, the data tells us that if you give IVIG even in snake bite, it's going to make the things better only. So the thing is, we as intensivists, we need to know and understand if the patient requires intubation and ventilation now, or we can delay it. So whenever we see such a patient, we should ask ourselves, will this patient survive with this feature that is there, that is sudden onset tachypnea, using of nasal and other accessory muscles? If you feel that this patient will not survive, then immediately intubate and secure the patient, and later on you give whatever you want to give. All right. Next question is on a similar neuromuscular emergency, that is myasthenic crisis. So in whole of the neurology, myasthenia gravis is taught, and whole of the medicine, myasthenia gravis is taught. But as an intensivist appearing for EDIC exam, the knowledge of the crisis situation that occurs in myasthenia is important for us. Why? Because myasthenia gravis can be managed on OPD also, OPD basis also. But it is only when the patient reaches a threshold where the patient needs to be addressed by an intensivist, that is called myasthenic crisis. So, a 63-year-old woman with known myasthenia gravis presents to the emergency room with increasing difficulty in swallowing, ptosis, shortness of breath over the last 24 hours. Whatever may be the reason, some medicine may be the reason, some viral infection may be the reason, some stressors may be the reason. We are concerned about the reason only after the patient has been secured. So we need to know if the patient needs securing right now. So the patient has a history of myasthenia gravis, has been on treatment. Now the patient is having increasing difficulty in swallowing, doses, and shortness of breath. She has had a recent respiratory tract infection and she is alert. The blood pressure is 130/75. Respiratory rate is 28. Saturation is 90% on room air. Which of the following is the most appropriate immediate intervention? Administer oral pyridostigmine, give IV corticosteroids, intubate and admit to the ICU, start broad spectrum antibiotics, या perform tensilon test. So the answer here also will be elective intubation of this patient. Why? Because this is myasthenia gravis with respiratory compromise. What are the features which are telling us? Number one is respiratory rate of 28 and number two is saturation of 90. Although the patient is alert, if you take a stand that this patient needs intubation, then you obviously will sedate this patient and then ventilate. But don't be ashamed of telling that this patient is going to crash in next 30 minutes. If we don't intervene now, we will have a dead patient or a patient who has crashed and we will be doing CPR. We can avoid that now. So what are the pointers? Number one is the respiratory rate of 28. What is the normal respiratory rate of human beings?
Around 18.
Yes, again?
Around 18.
So 12 to 15 is the normal respiratory rate with an average mean of 14. So if somebody is having anything more than 16, it is called an onset of respiratory distress. Anything above 20 is moderate respiratory distress. Anything above 30 is the defining criteria for quick SOFA. You remember quick SOFA? Quick SOFA for septic shock. So there the three main features are CNS obtundation, blood pressure of less than 80, respiratory rate of more than 30. So that is severe respiratory distress. So anything from 16 to 20 is mild respiratory distress, 20 to 30 is moderate, and more than 30 is severe respiratory distress. So this means before the patient lands up into severe respiratory distress, you have to intervene and intubate the patient just based on these two pointers. Forget it that the blood pressure is normal. Forget that the patient is alert. The patient may not remain alert in some time. And many people may have a contradictory response that why not try oral pyridostigmine? Why not give IV corticosteroids and wait? IV corticosteroids? Anybody? Any opinion about IV corticosteroids? So IV corticosteroids usually worsen the patient. It is only after the crisis situation has gone that you can start steroids. If you start immediately IV corticosteroid, then the patient will only worsen. And the patient who has not required intubation as of now will require it after the IV steroid has been given. So it is wrong to give IV steroids. Administering oral pyridostigmine is again contraindicated when the patient is impaired swallowing. See, she has a chief complaint that the patient has difficulty in swallowing. So dysphagia is set in. And if we give oral pyridostigmine to this patient, the patient might aspirate pyridostigmine into their respiratory airways. So one is wrong, second is wrong. Intubation is the right answer. Starting broad spectrum antibiotics is just a supportive act. It is not going to be immediate life-saving step in this patient. And what about performing tensilon test? Anyone? So tensilon test basically is a diagnostic for myasthenia. This is already a diagnosed case. You will not need to make a diagnosis. So it is a diagnosed case of myasthenia. So this answer is also out. This is also out. So the only answer is intubating the patient and admitting to the ICU. Always remember, if you are going for an EDIC exam, be prepared to be challenged for a situation where you will be required to be assessed as an intensivist, because this is an intensive care exam. So you must be having a very good insight of when to do what. We will be going into the details of all the questions, but before I'll just share the questions with you. All right. The next question is about botulism. A 28-year-old man presents with diplopia, dry mouth, and progressive descending weakness. Progressive descending weakness. So in Guillain-Barré, it is usually ascending weakness. In botulism, it is descending weakness. He reports eating home canned vegetables 48 hours ago. He is alert. His pupils are fixed and dilated, and deep tendon reflexes are reduced. No sensory loss is noted. Which of the following is the most characteristic of this condition? Number one, normal pupils with upgoing planters. Number two, preserved reflexes with patchy sensory loss. Number three, ascending flaccid paralysis and preserved cranial nerves. Number four, symmetrical descending flaccid paralysis with autonomic dysfunction, or acute spastic quadriparesis with preserved consciousness. What is the answer? Anyone?
Descending reflex.
So it is a symmetrical descending flaccid paralysis with autonomic dysfunction. Okay. So botulinum is usually defined with this criteria, that the patient has descending paralysis starting with cranial nerves. So remember ophthalmoplegia, facial nerve loss, trigeminal loss. So these are all present. Gag reflex will be gone. These patients usually have cranial nerve involvement as the first step. In Guillain-Barré syndrome, the cranial nerve involvement, for example, ophthalmoplegia, it usually comes later in the course. So in botulism, it is the reverse pattern. Cranial nerves first and then the descending pattern of the paralysis. The autonomic signs like dry mouth, fixed pupils, hypotension, they are pretty common. Reflexes are either absent or they are very decreased. Sensation, that is cutaneous, the dorsal column is usually preserved. Differentiating factor from Guillain-Barré is number one, the trend of the paralysis, that is ascending paralysis in Guillain-Barré and descending paralysis in botulism, and central causes. For example, spasticity, altered consciousness. These are basically the central brain causes which cause similar presentation, and we need to make a differential diagnosis from botulism. So that was about botulism. Remember, we will discuss each question in detail, but first we will have discussion on the questions right here. Okay, critical illness myopathy or polyneuropathy or CIP or CIM. A 68-year-old patient in ICU was there for 3 weeks with a diagnosis of sepsis. The patient was on ventilation and multiple organ failure was there. Eventually, the patient recovered, is still on ventilator, and we do not have a proper weaning off from the ventilator. That means it's a failure to wean off. Neurological examination shows diffuse weakness, especially proximal weakness, with decreased deep tendon reflexes and intact sensation. The nerve conduction study shows low amplitude CMAPs with preserved snaps. So, what is the most likely diagnosis? Can it be Guillain-Barré or myasthenia gravis or botulism? No. Can it be conversion disorder? It is very difficult to say conversion disorder in such a setting. Conversion disorder usually happens in a patient of outpatient setting, not an inpatient or a critically ill patient. So this is critical illness polyneuropathy. Now this typically occurs in ICU patients with history of septicemia and multi-organ involvement. Weaning of failure, diffuse weakness, and the preservation of sensation are characteristic. Nerve conduction studies, they help in differentiate this condition from others. Why? Because in critical illness neuropathy, there is low CMAPs, there are preserved snaps, which are pointing to axonal neuropathy presenting as proximal myopathy. And then myasthenia and GBS, though obviously they are very unlikely in this situation. Lambert-Eaton myasthenic syndrome. A 55-year-old man complains of progress. These are very important questions. I have framed them with utmost, care that has been taken not to miss out on anything, which is, these questions are very similar to the ones that come in EDIC exam. So you must be prepared and very, very ready. Small words are there which will be hinting towards the diagnosis and the correct course of action. A 55-year-old man complains of progressive lower limb weakness and dry mouth. He also has difficulty rising from a chair. That means there is proximal muscular weakness or proximal myopathy. Remember, proximal myopathy is defined as the poem that patient has difficulty in combing the hair and difficulty getting out from the chair. So this is poem. That means the proximal girdle of shoulder and the pelvis. Both of them are involved. So the patient has difficulty rising from chair but feels stronger after repeated movement. Reflexes. Now this is the main hint, that feels stronger with the repeated movement. In myasthenia gravis, patient feels weaker with the repeated movements. Reflexes are initially absent but improve after exercise. He is a smoker. Chest X-ray shows a right hilar mass. Which of the following best differentiates LEMS from myasthenia gravis? Ptosis is more prominent in LEMS. Symptoms, they worsen with repeated exertion in LEMS. Hyporeflexia with post-exercise facilitation in LEMS. LEMS presents with diplopia as the earliest sign. Presence of thymoma is there on the imaging. Anybody? What is the answer? But Eaton is a very important question.
Think we differentiate between both by hyperreflexia with post-exercise fasciculation and autonomic interference in Lambert-Eaton.
So basically, the patient has the Lambert-Eaton syndrome. Basically, what is hyporeflexia is there, which becomes better with post-exercise. So that is known as post-exercise facilitation. So C is the correct answer, that hyporeflexia with post-exercise facilitation is there in LEMS. So LEMS is characterized by number one, proximal muscle weakness. So patient will have difficulty getting out from the chair and combing the hair. There will be autonomic symptoms, that is dry mouth. Hyporeflexia will be there, which improves with exercise, often associated with small cell lung cancer. So it is basically a paraneoplastic syndrome. Myasthenia, on the other hand, has worsening with activity and more ocular movement involvement. Sorry. And thymoma is associated with myasthenia gravis, not LEMS. And if myasthenia gravis has a history of a lung cancer, then it is not myasthenia gravis, it is LEMS. So key features of all these. Now you can take a snapshot of these key neuromuscular emergencies. You can take a snapshot. On one page you have all of them. That is, Guillain-Barré syndrome has ascending flaccid paralysis, needs early intubation if you have earliest signs of neuromuscular weakness affecting the respiratory muscles. Then myasthenic crisis, worsening respiratory or bulbar symptoms, prompt airway protection will be needed. Botulism has a descending paralysis, autonomic signs will be present, cranial nerve involvement will be there, and the history of exposure to home canned foods, or basically dried fruits will be there, which can be infected with Clostridium botuli, the organism of which the toxin is produced, which affects the neuromuscular junction of the mammals. Then is critical illness polyneuropathy or critical illness myopathy, which is particularly in the setting of ICU patient. So it is an ICU acquired weakness. There will be a reference to failure to wean off the patient, and there will be a reference to the need of supportive care in a patient, trying to manage their blood glucose levels, keeping their magnesium and other electrolytes in normal range, providing them with good calories, and doing stimulated graded level of exercise so that their muscular activity gets better and better. Then comes the LEMS. LEMS is basically a paraneoplastic syndrome with Lambert-Eaton myasthenic syndrome. Is basically a syndrome related to small cell lung cancer, and it is associated with proximal muscular weakness, which gets better with activity, unlike the myasthenia gravis, and is associated with lung cancer. So let's do go through the conditions. First is the Guillain-Barré syndrome. So Guillain-Barré syndrome is basically an acute immune-mediated. Every word is important. Is an acute immune-mediated polyradiculoneuropathy, often triggered by infections of respiratory or gastrointestinal system involving Campylobacter jejuni, cytomegalovirus, Epstein-Barr virus, sometimes influenza, swine flu, and chikungunya, and this respiratory disease, which is COVID. So because it is acute, the patient will not get time, as the rapidity with progression that you can see in these patients is massive. You have to get involved very fast. And if at the earliest sign of noticing that the patient has a decreasing vital capacity, what is the best vital capacity test that you can do at the bedside for a patient of GBS? It is single breath count. So you tell the patient to count from 1 to 100 in a single breath, and you also count along with the patient. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33. So I counted till 33. I'm sitting right now. So if you see that the patient has got breathless less than 20 count, this patient needs intubation. That means 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. If the patient is unable to speak till 20, then this patient definitely needs an intubation. Do not put a patient of Guillain-Barré on NIV, because non-invasive ventilatory support needs patients, number one, muscle strength, number two, consciousness. If the patient is on NIV and the patient has Guillain-Barré, eventually the patient's muscle tone will get poorer and poorer. the patient will start retaining CO2, eventually become drowsy. And if you intubate by then probably the patient would have aspirated by then. So the clinical features are symmetrical ascending weakness that starts in the legs and progresses upwards. There is stark areflexia. There may be involvement of cranial nerves in the feature of bilateral facial palsy or ophthalmoplegia, that is of this pullomotor nerve involvement. Respiratory muscular weakness is important because this is where we pitch in. Risk of respiratory failure and trying to avoid it. Then autonomic dysfunction, BP instability, arrhythmia, and urinary retention is there. So these patients, they are diagnosed on a clinical suspicion of presentation and history and examination. Uh, very interestingly, the lumbar puncture will show a very distinct kind of a picture, which is elevated proteins but normal cells. So albuminocytological dissociation is there. Nerve conduction studies are a diagnostic. They show demyelination pattern and are gold standard. So sometimes the neurologist professors and HODs of neurology department, they become offended if you say that the patient has Guillain-Barré and you have not tested the patient for nerve conduction study, because otherwise you cannot make a diagnosis. ABG is required to assess the respiratory compromise and tachypnea leading to hypocapnia and maybe hypoxia at later stages, or respiratory alkalosis are the earliest features to identify the patient who needs an intubation. The ICU considerations are again revolving around the need for intubation. That is, elective intubation is done when respiratory parameters are worsening with vital capacity of less than 15 ml per kg. The treatment required is IVIG or plasmapheresis, equally effective. Steroids are not effective. Then comes myasthenic crisis. Myasthenia crisis is also an acute condition. It is basically an exacerbation of myasthenia gravis, but in an acute fashion, leading to very rapidly progressive respiratory failure, usually triggered by certain infections, medications, or stress. This of bulbar dysfunction, very important. In Guillain-Barré also they develop, but at a later stage. In myasthenia, they develop much earlier. So there is dysphagia, unable to swallow, there is dysarthria, there is dysphonia, the patient starts developing an nasal band voice, ptosis is there, diplopia is there, and then there is proximal limb weakness, eventually respiratory distress, but the patient has a preserved sensation and cognition. This is important. Differentiate the disease from other neuromuscular causes. Diseases. Diagnosis is already a known case of myasthenia gravis with antibodies present. That is the MuSK antibodies or the anticholine receptor antibodies. You can do an heterophonium or a tensilon test or EMG, which is diagnostic. But at the time of presentation, if the patient has a history of myasthenia gravis and has a rapidly developing respiratory paralysis, this is myasthenia crisis. Rarely, a myasthenia gravis patient can also develop GBS, in which situation it becomes very important for you to intubate the patient very early, because myasthenia gravis and this Guillain-Barré can be differentiated from number one CSF study and also from a nerve conduction study. So if you can do that in time, you can actually say that this patient is not a myasthenia aggravation, it is basically a Guillain-Barré syndrome in a setting of myasthenia gravis patient. ICU management, elective intubation is required before fatigue or hypercapnia sets in. You have to hold all the cholinesterase inhibitors if intubated to reduce the symptoms, because you just need to intubate and ventilate. If the patient is on controlled ventilation, you are least bothered about respiratory paralysis due to. Start IVIG or plasmapheresis, same as in Guillain-Barré, because I told you both of them will be helpful. Steroids with caution can worsen the initial myasthenia crisis and trigger the underlying trigger. Treated very aggressively, for example, infection. Now the next comes botulism. Botulism is a is a rare neuroparalytic illness caused by botulinum toxin, which inhibits the presynaptic acetylcholine release. So in myasthenia gravis, it is the postsynaptic problem. In botulism, it is the presynaptic problem. Home canned foods, infants can get it from honey, wound contamination leading to clostridial colonization. All of them can cause botulinum. Clinical features: the patient has symmetrical descending paralysis with cranial nerve involvement and diplopia, ptosis, dysarthria. They are very early because it begins from the cranial nerve and downwards. So limb weakness will follow. Fixed and dilated pupils are there. Autonomic symptoms like hypotension, shock, dry mouth, constipation. All of them. Interesting thing is sensation and cognition are preserved like in myasthenia gravis. Diagnosis is clinical. You can confirm it by toxin assay, which takes time. You can prove that the patient has Clostridium toxin in the body. Nerve conduction study is the gold standard. Low CMAPs and post-technic facilitation will be there. Treatment is supportive until the botulinum toxin has, dissociated itself from the neuromuscular junction. Equine antitoxin is available. Early administration improves outcome. Generally, just intubate these patients and let the toxin effect go away. This is just like snake bite. Not given anti-venom, eventually the patients will recover. So treatment is supportive care, ventilation if respiratory failure is there, and monitor for complications. Critical illness, polyneuropathy and myopathy. It is basically an acquired condition in critically ill patients, commonly with sepsis, multi-organ failure, and prolonged ICU stay. It is of two types. CIP is basically defined as sensory motor axonal polyneuropathy. So CIM is primary myopathy with protein loss, that is myosin loss, and usually both of them they keep overlapping. So diagnosis is by nerve conduction studies. In CIP, there is low CMAP and SNAP both. In myopathy, CMAP is low, but SNAP is normal. EMG is abnormal, so muscle is mainly the diseased organ. So muscle biopsy may be helpful in diagnosis, but usually you can make a diagnosis out of experience also. So you should increase the weaning of trials in a graduated manner. Use a DVT prophylaxis, early physiotherapy, control the hyperglycemia, avoid any neurotoxic drugs wherever it is possible. Coming to the last topic of this question series, Lambert-Eaton syndrome, basically an autoimmune disorder affecting the presynaptic PQ type calcium gated voltage channels, impairing acetylcholine release. So basically, it's in myasthenia gravis, it was the anticholine receptor antibody which are blocking the distal part. Here it is the release of the acetylcholine which is affected. Usually it is associated with small cell lung cancer. So it is a paraneoplastic syndrome. Clinically, there is proximal muscle weakness, legs more than arms, hyporeflexia or areflexia is there, autonomic symptoms are there, which are dry mouth, impotence, orthostatic hypotension. Facilitation strength improves with repeated activity, ocular involvement is rare, and differentiate from myasthenia gravis. Clinical exam is diagnostic. Repetitive nerve stimulation will show incremental response. VGCC antibody can be tested, screen for malignancy, chest X-ray or CT chest. What is the treatment? The treatment is to treat the underlying tumor, immunotherapy like steroids and azathioprine. 3,4 DAP enhances the acetylcholinesterase release or IVIG or plasmapheresis in severe cases. So this was the topic on neuromuscular diseases emergency or the exacerbation and its management in ICU. I hope the topic was clear to you, because then we will move on to the next topic. Okay, any questions from that? All of the 5 topics are covered. So you please go when you are, after the class, try to go through these 5 topics again, and you will be excelling. Try to do at least 5 to 10 questions of each topic that I have just told you. Most of your EDIC, this neuromuscular disorders will be covered. Now coming to coma and disorders of consciousness. Now, so coma scales, there are 2 types of coma scales which are usually evaluated in EDIC exam. One is the GCS that we all know, then is 4-score. So let's see how it is implemented. A 62-year-old man is found unresponsive after witnessing a cardiac arrest. He is intubated and brought to ICU. On exam, the patient has no eye opening, no verbal response, and localizes to pain, Pupils are equal and reactive. Corneal reflex and cough reflex are intact. The ECG is absolutely normal and unremarkable. Which of the following best describes the patient's neurological status using the 4-score? 4-score 0, 4-score 2, 4-score 4, 4-score 6, 4-score 10. Anyone? So basically 4-score includes 4 domains. One is the eye response, the other is motor response, third is brainstem reflexes, which is like pupils, cornea, cough reflex, and respiration, which is R. So in this patient, the patient has no eye opening. Patient has no eye opening. So the score is 0. The patient has no verbal response, but that is not included in 4-score. Patient localizes to pain. This is motor response. So localizes to pain. Pupils are equal and reactive. So this is brainstem reflexes. So brainstem reflexes are cornea reflex and brain cuff reflex are intact. So this is again 0. The localizing to pain is basically 3. Okay. And the respiration is patient is basically on ventilator. So respiratory is 0. So this patient has so 3 plus 4, 7. How 7? So, but 7 is not the, in the option. So 6 is the nearest. So we will mark the 6. So correct answer is 6. The 4-score includes 4 domains: eye response, motor response, brainstem reflexes, and respiratory response. So this is, we will do the 4-score later. Unlike GCS, 4-score is more useful in intubated patients and allows better assessment of the patient and prognostication. A 46-year-old woman with history of chronic alcohol use presents with progressive drowsiness. Now, on examination, the GCS is 9. Pupils are equal and reactive. The horizontal gaze is paralyzed. There are no lateralizing signs. The CT head is normal. Labs are showing 130 sodium, that is hyponatremia, glucose of 5.2 and ammonia of 110. Which of the following is most likely cause of her altered consciousness? Is it brainstem infarction? Is it hepatic encephalopathy? Is it Wernicke's encephalopathy? Is it hyponatremia? Or is it hypoglycemia?
Vernix encephalopathy to be treated with cyanide.
Say again.
Vernix encephalopathy to be treated with cyanide drugs.
So we have number 1, we have to identify that this is metabolic encephalopathy. Now, the hints that are there is chronic alcohol use, so it can be Wernicke's as you rightly said. It can be hyponatremia. Again, it can cause metabolic encephalopathy. But ammonia is also elevated at 110, so it can be hepatic encephalopathy. Now, this patient has progressive drowsiness. The GCS is only 9. Pupils are equal and reactive. Glucose is normal. Glucose is normal. So, Wernicke's are very less chances with normal glucose. So, this patient has likely hepatic encephalopathy because the ammonia is elevated, and although the other features are also there, but having a normal glucose will tell us that this is hepatic encephalopathy affecting more. Progressive drowsiness is there, which is also causing it. So this patient is oscillating between hyponatremia and hyperammonemia, but having 130 sodium will not push the patient to a level of drowsiness. The hyponatremia is only mild, so we will not consider that as the cause of encephalopathy here. And glucose being normal, Wernicke is out. So the only thing that is left is ammonia of 110, which is hyperammonical encephalopathy or hepatic encephalopathy. There are no lateralizing signs and preserved pupillary reflex. This indicates the patient has metabolic. Now, very high ammonia against a backdrop of less than 30 is suggestive of hepatic encephalopathy. Hyponatremia is mild and glucose is normal, so Wernicke's and hyponatremia are also ruled out as a cause of encephalopathy here. A 75-year-old woman presents with coma of unknown etiology. She has no focal neurological signs. CT brain is unremarkable. EEG shows periodic generalized spike and wave pattern. She receives 2 milligram lorazepam IV and becomes unresponsive. What is the likely diagnosis? Is it brain death? Is it structural brain stroke? Is it non-convulsive status? Is it hypoxic ischemic encephalopathy? Or is it psychogenic unresponsiveness? So basically the pattern of EEG that was given here, that is spike and wave discharges, this is suggestive of non-convulsive status epilepticus. So EEG with generalized periodic discharges and clinical improvement with lorazepam or any benzodiazepine is diagnostic of NCSC. It is an important reversible cause of coma. Structural lesions will not respond to lorazepam. Psychogenic states typically show a reactive EEG and a normal brainstem function. Neuroimaging in coma. A 55-year-old hypertensive male is admitted with sudden onset coma. So he was normal. He is 55 years old and he has suddenly become unconscious. The BP is 190 by 110. Examination shows gaze deviation to the right side. There is left-sided hemiplegia. The pupils are pinpoint. GCS is 5. CT shows a large pontine hemorrhage. Which of the following clinical features is most characteristic of a brainstem structural coma? Reserved responses, early hemiparesis without cranial nerve findings, reactive EEG or pinpoint but reactive pupils, or Cheyne-Stokes breathing. So the answer is pinpoint but reactive pupils. So correct answer is pinpoint but reactive pupils. So the pontine lesions, they cause these features. Number one, pinpoint pupils due to descending sympathetic pathway interruption. Pupils may still be reactive if Edinger-Westphal nucleus is spared, but the communication due to a descending sympathetic pathways interrupted will be gone. So the pupils are small sized. Cortical lesions, they typically spare the pupils. So if somebody has a cortical infarct or a cortical bleed, the pupils will be normal. It is only the involvement of the pontine region which leads to such a condition, which is called brainstem coma. Very important topic these days, prognostication after cardiac arrest. You will not find these questions elsewhere. So 60-year-old man is comatose after out of hospital cardiac arrest. He underwent targeted temperature management, that is TTM, at 33 degrees centigrade for 24 hours. On day 3, he was he has absent pupillary and corneal reflex, status myoclonus, bilateral absent N20 potentials on SSEP. Which of the following best describes his neurological prognosis? High chance of full neurological recovery, likely to remain in minimally conscious state, poor prognosis, further testing is required, highly specific predictors of poor outcome, cannot assess prognosis until day 7. So basically, it is a poor prognosticating indicator. Now, highly specific predictors are there for the poorer outcome. For example, uh, absent brainstem reflexes, presence of myoclonus, or absent SSEP bilaterally at least more than 72 hours after the return of spontaneous circulation indicates that the chances of neurological outcome are poor. So the answer is highly specific predictors of poor outcome. So the poor indicators after the temperature maintenance is after more than 72 hours post ROSCR. Number 1, absent brain reflexes, brainstem, status myoclonus, absent N20 SSEP bilaterally. So these patients have high specificity for poor neurological outcome. The guidelines, they recommend multimodal prognostication after 72 hours of normothermia. Such is the importance of uh, brainstem death in Western world, and you should know them by heart. So now let's go through the topics: coma scales, GCS, and 4-score. So we all know about the GCS, and the GCS is assessing eye-opening verbal and motor response ranging between 3 to 15. Not applicable in intubated patients because they cannot speak, lack assessment of brainstem reflexes or respiratory pattern. We know that the maximum score in E, that is eye opening, is 4. In V, that is verbal response, is 5. And M, that is motor response, is 6. So out of 15, either somebody can have a 15 or somebody can have a 3 minimum. So it is when the patient is intubated, you cannot assess them for verbal response. Hence, there is no point, although we keep mentioning E1, M2, VET, that is endotracheal tube, but that is a modification which is not generally accepted. So it is not a valid test in intubated patient. Whereas 4-score, which is full outline of unresponsiveness, designated for intubated ICU patient, total score of 0 to 16, 4 components of eye, motor, brainstem, reflex, and respiration, EMBR. So components are eye response is 4, full tracking, motor response 4, obeys, brainstem reflexes 4, all present, breathes regularly also has 4. Advantages are useful in brain death prognostication and in patients with not verbal response. So these are very important scoring system, GCS and 4-score. Okay, 4-score is 0 to 16, so can be 0 also. So these are the maximum eye response 4, motor response 4. These are maximum, 0 is minimum. So somebody can have 16 as the maximum score. Metabolic versus structural causes of coma. The metabolic diseases usually have diffuse symmetric findings. Pupils are often normal and reactive. Common causes are hepatic with increased ammonia, hypoglycemia, hyponatremia, drug overdose, toxin overdose, and thiamine deficiency leading to Wernicke's encephalopathy. Then there is structural coma, which presents with focal neurological signs, abnormal pupillary responses, brain imaging like CT and MRI, which are often abnormal. And examples are brainstem stroke, maybe hemorrhage, maybe non-hemorrhagic infarct, trauma or hemorrhage due to trauma, mass lesions with herniation. So these are important. Now coming to EEG in coma. So very important. We discussed a case where it was a patient of non-convulsive status epilepticus, and we keep seeing these patients in the ICUs. Seldom do we find the exact reason which led to the onset of non-convulsive status. Many times it's electrolyte deficiency, many times it is some drug like imipenem which has been given and the patient develops NCSC. But the hallmark is to use an EEG. Why? Because EEG differentiates between non-convulsive status epilepticus and hypoxic ischemic encephalopathy. EEG can diagnose locked-in syndrome, psychogenic coma, and even brain death if it is a straight line. EEG is used in prognostication after post-cardiac arrest. The key patterns are generalized spike and wave discharges are seen in non-convulsive status. Burst suppression are seen in deep coma due to post-anoxic brain injury, or thiopentone or phenobarbital that is given to control the nerve non-convulsive status. Alpha coma, poor prognosis, usually hypoxic ischemic encephalopathy. Flat EEG, also known as isoelectric, is seen clearly in brain death with other confirmatory signs. Now comes the neuroimaging in coma. Now, neuroimaging is very important when it comes to critical care of the neurological system, that is neuro ICU. So, every patient needs to have a CT head if it is not contraindicated. So, if they have, immediately CT head should be done. First line in structural coma, don't go for MRI because these patients are confused and restless. There is no point in sending the patient for MRI when they will come back without having done anything. So it is good and it is perfectly fine and gold standard to get a CT brain to rule out the first reason of altered mental status. Defects usually detects hemorrhage, mass effect, herniation, or hydrocephalus. MRI is very sensitive for brainstem infarct, early hypoxic changes, posterior reversible press, which is syndrome encephalopathy, and Wernicke's encephalopathy. No doubt, MRI is very sensitive there, but it needs more time, around 30 minutes to get done. Pupillary clues are pupil finding and possible lesion. So, undilated by pupil, unilateral, dilated pupil is due to third nerve compression. Pinpoint reactive pupils are used due to pontine hemorrhage, which also causes high-grade fever. And mid-position fixed pupils are seen in midbrain lesions. After cardiac arrest, we usually assess the patient after 72 hours of ROSC, initiate rewarming if the TTM was used. Predictors of poor outcome are absent pupillary and corneal reflexes, no motor response, absent N20 responses to SSEP, unreactive or burst suppression of EEG, and presence of status myoclonus within 24 hours. So if somebody has a status myoclonus, there is no point in continuing the treatment of the patient. So this patient is already a gone case where status myoclonus starts up. Targeted temperature management, that is TTM, is maintaining a temperature of 32 to 36 degrees for 24 to 48 hours. It reduces the secondary brain injury either after trauma or after stroke. It can delay the recovery, hence prognostication should wait until the rewarming has been attempted. Biomarkers are also there, like neuron-specific enolase, which is more than 33 microgram per liter at 48 to 72 hours and suggests poor outcome. It should not be used in isolation. There are certain key points that you need to remember. GCS versus 4-score. So 4-score is very good in intubated, sedated patients on ventilator because we do not have the voice scoring in 4-score. It is superior in ICU and intubated patients. Then is metabolic versus structural. Metabolic are usually synthetic, they have reactive pupils, and local signs are pretty grave. So, EEG in coma, useful in non-convulsive status epilepticus, very important nowadays. The emphasis is on continuous monitoring of the EEG. Hypoxic ischemic encephalopathy, brain death. Lorazepam trial also can be given, but it is should be with the intubation standby. Neuroimaging CT is recommended for almost all these brain-related situations or altered status, because CT head is, immediately can be done fast. MRI is detailed, needs time more than 30 minutes. Brainstem lesions are often subtle. Prognosis after post cardiac arrest, wait for 72 hours. Don't rush to tell the patient that you will not survive. Post TTM, use multimodal predictors like EEG, SSEP, and clinical examination to prove the brain death. So these are the important topics that were left in the first class that we have covered today. So if there are any questions, you may ask now, or you may send it to Sana, and I will respond in my text message. If anybody needs any specific MCQs or detailed discussion, just let it be known to Sana, and we will cover that.
Thank you, sir.
Thank you, doctors. Thank you, Sana. Have a nice evening and a good weekend.